Thank you. Can you hear me? Yes. So I'm really a community psychiatrist, so I'm very grateful to the Brain and Behavior Foundation and to you all for the support that allow me to continue my research at Massachusetts General Hospital. The picture here is actually a picture from our hospital, and I work at the Depression Clinical Research Program. The topic is enhancing brain metabolism for major depressive disorder. These are my disclosures. So what we're going to talk about is about depression as a state of abnormal brain metabolism, and as well as antidepressant treatment as a way to reverse that state of abnormal brain metabolism. We're going to talk more specifically about this new treatment which specifically targets brain metabolism, which is near-infrared light, its mechanism of action, and its effect on memory, attention, depression, anxiety, and also traumatic brain injury. So let's talk about depression as a disease of lower brain metabolism. There have been studies, PET study, positron emission tomography studies, that have shown a decreased blood flow and an abnormal blood flow and an abnormal glucose intake in different areas of the brain, especially prefrontal areas and the cingulate cortex, that is cortex that is in between the two hemispheres, hiding right there. There have been studies, MRS studies, that have shown that a specific bioenergetic intracellular molecule or a set of molecules called nucleoside triphosphate are actually changed. Their change is associated with recovery from depression. So patients who ended up recovering from depression were actually boosting this amount of readily available energy in their brain cells. Our group, Iosifescu et al., has specifically shown in a study of augmentation with thyroid hormone of regular treatment for depression, SSRIs, that patients who responded to depression, in terms of their depression, responded to the augmentation with thyroid hormone, were actually increasing the availability of NTP, which is this readily available form of energy in the cell. And they also were decreasing their storage of energy, meaning that the response to treatment corresponded to greater availability of energy in the cell. So this was the first proof that the treatment could reverse the state of abnormal metabolism in depressed patients. And Dr. Iosifescu from our group went on replicating that with just plain antidepressant without the thyroid hormone. Now, let's talk about near-infrared light. Above here, you can see the spectrum of light. Here is the visible light. And for light that has a smaller wavelength, you would have on that side of the spectrum the UV, the gamma rays, the X-rays. So technically the most dangerous and most energetic light. On the other side of the visible, instead, there is the infrared, which is after the red. And then you don't see it here, of course, the radio, TV, microwave, other light that we use safely. The near-infrared light is very interesting because it has specific properties. First of all, it goes through the tissues and it's not absorbed by the melatonin, it's not absorbed by the hemoglobin, so several chromophores that could hide basically, or prevent the penetration of this light. Now, we are actually all bathing in infrared light. 50% of the sunlight is infrared light. But what is most important is for us this range between 700 and 1,000 nanometer, because that is the light that is specifically absorbed by chromophore in the mitochondria, which are the energy, the power plant, let's say, of the cells and the neurons. So this light allows, as you can see in this picture, by penetrating the tissues, allows to bring energy right in the mitochondria, and somewhat in parallel to the energy that comes through the glucose, which is the major and fundamental fuel for the brain, allows to bring energy in the brain. Now, this picture over here shows a laser. In fact, this light can be shed as scatter light. The scatter light is the light you see on me that goes pretty much everywhere. The laser is a directed light, and it's on phase. So if you think about the wave, they're all synchronized. This is a laser. I'm pointing right now. Your CD-ROM is a class 1 laser. Your scanner at your market is, as a matter of fact, a class 2 laser. This is a class 3 laser. And there is the actual instrument that we're using for biomedical use are class 4 laser, which have higher energy and therefore are somewhat more dangerous. And the major risk is the retinal injury if the laser is shed through the lens and focusing then on the retina. Therefore, you will see wear specific glasses because of that. Let me go back and talk a little bit about the mechanism of action. I did mention to you that this light will bring energy to the cells. And it does have, in addition to that, a cascade of effect, which include anti-inflammatory effect by decreasing the tumor necrosis factor and interleukin-1. We have to say that depression has also been theorized as an inflammatory disease. So that could also be a way this light might help in depressed patients. It also increases the brain-derived neuronal factor and the nerve growth factor, increasing basically the neurogenesis and producing new synapses as well. And also it reduces the oxidative stress. So there is a variety of possible mechanism of action of this new treatment. Now, this is actually the best evidence that we have as today about the effect of near-infrared light in humans. This was a study conducted by Barrett and Gonzalez-Lima at the University of Texas in undergraduate students. They divided them in two groups. They were randomized to either receive the light or a sham, which was just producing enough light to warm up the skin so that people wouldn't feel the difference or wouldn't know. It was only one session at the right frontal pole. That was the target. And there was a 2-week follow-up. These are the parameters. The instrument used was a laser. And what they have shown by using the positive and negative scale, affect scale, they shown here in black, the people treated were maintaining a better affect over time. So I'm not sure whether the finals were coming up and these were getting a little bit discouraged here, but certainly you might be familiar with that experience. Or maybe the enthusiasm of getting into the study, and the same enthusiasm was kept over time, but there was a clear and significant difference. They also went on checking with other tests, the psychomotor vigilant test, where people had to react to a probe appearing in a computerized screen, and they look at the time to react, and of course, less time is better, means that you are more reactive. And here, the people who were treated were in fact having a lower reaction time, and they were doing significantly better at 2 weeks. They also looked at the delay match to sample test, where people were shown a plot of red and yellow squares, and then they were presented with 2 different pictures, and of course they had to recognize which one was the match of the previous plot they had seen. And of course here we looked both in terms of correct trials, and again the people who received treatment have a higher number of correct trials, but also took less time, the latency, than people who were not treated to find the answer. Let's talk now about the evidence, and this is really just a case report of the use of near-infrared light in traumatic brain injury. These are 2 cases. One was a 52-year-old university professor, was also a book writer, had written 3 books, was actually working for an internet marketing company, and was the marketing manager of that company. Ended up having a motor vehicle accident and being diagnosed with a status post concussion syndrome. Had severe memory impairment, attention impairment, executive function impairment, went on developing depression, having also a suicide gesture, and was eventually treated with near-infrared light. And her span of attention on a computer went from 20 minutes to 3 hours. So it was an amazing change in her performance, and was able eventually to resume work, and so it was a very successful. This person, at the time of this case report, had been treated for 6 years. The other case was the case of a 59-year-old woman who had a distinguished career as a high-ranking officer in the military, and was an executive consultant for a firm, and developed actually several traumas in her lifetime due to sports, rugby, skydiving, and also to deployment. And then develop a severe trauma with loss of consciousness, falling backward on concrete, and then had pretty much the same impairment I mentioned in the other case. She also developed PTSD as a result of this event. Went on being treated and had an impressive improvement. And here, actually, we have some of the cognitive testing for this person. The Stroop Test was based on naming colors, words that are coming on a specific ink color, and naming that color of the word with a confounding of the word referring to a different color. So think in yellow, RED, So you're thinking red, but you have to say yellow. This person had an amazing improvement, showing that her prefrontal lobe was working much better, inhibiting this confounding. The same patient here had some atrophy, as you can see from this deeper sulci in her frontal lobe. What is interesting about these patients is that they had a very prolonged treatment on a daily basis and several sites, and not only prefrontal cortex, but also the temples, parietal sites, and they did tolerate well. And they had also emotional benefits with better control, better self-regulation of their affect, less irritability, less anger. Okay, this is actually an open study that was conducted in McLean in Belmont, that is affiliated with Mass General, of subjects with major depression. These subjects were treated bilaterally, and you can actually see the picture over here. And as I told you, they were wearing glasses specific to prevent the light from passing. And this patient had remarkable improvement with now scatter light. This wasn't a laser. Here on top you see the depression rating scale was the Hamilton 21, and their score dropped at week 2, and it was still lower at week 4. This was not just depression, but even the anxiety dropped dramatically. And this was just with one treatment, of course, at the beginning of the study. And the rate of remission was about 60%, so quite impressive at week 2. Again, well-tolerated treatment. These are our data from Mass General, from the depression clinical research. Here we experimented multiple treatments of NIR. I can show you this data today because we are actually changing our instrument. So we broke the blind, and we have now preliminary data. But we are now we're about to start our second year of award, and we'll finish up the study with a new instrument. These were patients with major depression. This was a double-blind crossover study of near-infrared light versus sham. 2 sessions per week for 3 weeks. Again, irradiating the dorsolateral prefrontal cortex. And the overall study was a 7-week study. And we also had a baseline MRS spectroscopy to look at those molecules that we had mentioned at the beginning that are indicating high energy availability and the process of conversion from the storage of energy in the cells through some phosphate compounds to those readily available energy molecules that are the NTP. So these were the results. We did have 8 patients at the beginning, and 3 of them actually dropped soon in treatment, but these were actually patients who were assigned to the sham we discovered. So that was unrelated to the actual light treatment. And as a matter of fact, 2 of them were actually discouraged by the frequency of treatment and visits because the patients needed to come to the unit twice a week. These are the parameters. We used a class 4 laser, and these are some of the settings you can see. Overall, there was a dramatic decrease of the Hamilton rating scales for depression, and of the 4 completers that had near-infrared light for the first 3 weeks, 2 of them had a complete remission at 6 and 7 weeks. So that was a pretty interesting finding. And of course, we're hoping to replicate with the new instrument. This is another group in Denver, Colorado, the Neurolaser Foundation, that has an open study now with pulse light instead of continuous light, with, again, multiple treatment, 2 to 3 sessions per week, still dorsolateral prefrontal cortex. And what they claim is that continuing the treatment for about 8 weeks actually led to a sustained improvement in many patients over time for more than a year. This is interesting because this could be a sign that this treatment could actually be used a little bit like ECT treatment or TMS, have a course of treatment and then have a prolonged remission. The effects were on mood, anxiety, and sleep. The sleep was actually, interestingly, very much improved in the TBI patient, the traumatic brain injury patient as well. So the conclusion are that near-infrared light is safe, and I want to add here that data of safety are not just limited to what you have seen here, but this treatment has been extensively used for stroke, with more than 400 patients treated for stroke in neurology, and there were no cases reported of either skin burns or macular degeneration, so it was a very safe treatment. Eye protections are used whenever a class 4 laser is used. It seems to be effective for depression, anxiety, cognitive impairment, and most likely these effects occur through the enhancement of the brain metabolism. It's also a treatment that can be easily disseminated, as some of these devices are already marketed, and some are just beauty devices, like the device that we're going to use is currently FDA approved for the treatment of periorbital wrinkles. So those are devices that are good to have, actually. I wanted to thank my colleagues, especially Dan Yusufescu and Maurizio Fava, that have been mentoring me along these years and allow me to be here today, and the other members of the group that have helped me evaluating the patients and other people that have given me useful feedback. Thank you.
Remember, I said the remarks I made with Dr. Ishizuka's paper, many of them also apply to this paper. In addition, there's a couple of things about this paper that make it sort of near and dear to my heart. One is that I've known your father for 35 plus years. Maybe I'm even older than your father, I don't know. And also because my group in the 80s developed light therapy, and people didn't take light therapy for seasonal depression very seriously. Light, how could light affect the brain? And now this is getting that much more sophisticated. And then, of course, I liked it because we did the first work, Art Prang and I, on T3 augmentation, which is an energy phenomenon. So there's those 3 different ways that I feel very connected to this one. Now, if you put this in the context of where we are as a field today, the industry is getting out of the business of drugs for us. You know, the payoff is too low, the risk is too high, the regulatory burden is too high. And now we really need non-pharmacological alternatives, and this one I think is quite exciting. And I like the fact it's available because, I mean, people can get out and test it easily without having to wait for some special research thing. One of the things about this is that for many, many years, all we paid attention to was neurotransmitters and receptors, monoamine receptors. We're going back to the 60s, basically. And all our drugs were modeled on that, all of our theories are modeled on that. This is now looking at bioenergetics and mitochondrial function. And I recently had to write a foreword for a book. I was just floored by the amount of work on mitochondrial dysfunction and mood disorder. It was like under the it was like under the surface. You never see a presentation APA or anything. It was just there, and there's an amazing number of findings. And also, with magnetic resonance spectroscopy, you can actually measure the chemicals like NAA, N-acetyl aspartate. You can measure that directly in the brain of human patients. And so this whole area of mitochondrial function in mood disorders and other psychiatric disorders is just beginning to explode. By the way, with your dad, do you think your influence with him was genetic or environmental or both? So, again, I find this very exciting, and it certainly fulfilled my need to get educated, because I learned a great deal in reviewing the literature to prepare these comments. If you think about what his light is doing, it kind of converges on some of the hottest areas these days in relation to mood disorders. Neurotrophins, neurogenesis, synaptogenesis, neuroplasticity in general, anti-inflammatory. There's a whole new emerging literature about inflammatory dysregulation in mood disorders and anxiety disorders. Oxidative stress, free radicals, all this stuff is a relatively new frontiers in brain science related to mental health. I, of course, at my age, am particularly interested in the memory effects. That's why I want to go out and get one of these things and try it. I like the review of the traumatic brain injury, because if people aren't going to take this serious and say, well, depression, it's all subjective, and, who cares? Traumatic brain injury, if you can fix traumatic brain injury or even significantly help traumatic brain injury, that's dramatic. And that's not going to that's going to get people's attention. Now, one of the things I might want a little more detail about, and again, this is just a methodological point, you did a completer analysis. The issues with completer analysis is who are the non-completers, and you said 3 of them happen to be in the placebo group, which is good. But in many studies, like in drug addiction, it's very hard for an addict to complete treatment. So the group that complete are, the ones that are doing best. So it's always important to monitor dropouts and ask questions about who the dropouts are. And often people who stay in the study have the most motivation to get better, which may associate with clinical response. But to me, this was without question a major advance in therapeutics. I really mean that. I mean, I think there's so many other things that have been done with it. It's been checked out in some pretty serious conditions. I think there's something real here. And my God, does our field really need something new? I mean, therapeutic optimism has been getting a little hard to find. And if you have something that's both novel and effective, we're entitled to feel some therapeutic optimism about this. So we need to, of course, the fact that it's readily available means there's going to be a lot of studies of it. We'll learn about its limitations. We'll learn about its potential in other areas. We'll define what non-response means to this treatment, how they're different from responders. So all that's going to start churning in the literature in the next few years. It's going to be very exciting. So thank you very much.